Welcome to the deep dive. We are tackling one of the most critical and complex topics in high-stakes obstetrics today.
That's right.
It's the whole spectrum of dysfunctional labor. We're moving swiftly from, prolonged progress that just drains reserves right up to the very brink of life-threatening mechanical obstruction.
Yeah, and this isn't just about memorizing, like, time limits from a textbook.
No.
This is really about achieving the mastery you need for immediate, flawless clinical judgment in these situations.
Exactly.
Our mission today, really, is to dive deep into this textbook material. We need to understand the precise definitions, yes, but also the subtle differences between these disorders. And crucially, the definitive management principles required when failure to progress becomes a true emergency. We have to become expert guides, navigating those interactions between the three Ps: power, passage, and passenger.
Okay, so you sent us these incredibly dense textbook excerpts. They're focusing on prolonged labor, obstructed labor, and then dystocia specifically caused by fetal anomalies.
That's the core material, yeah.
So we are going to meticulously unpack those sort of arbitrary time limits people talk about. We'll look at the crucial warning signs you see in that essential clinical tool, the partograph.
The partograph is key.
And then we'll run through the specific drills, the maneuvers required in sudden emergencies like shoulder dystocia. This is basically our masterclass in real-time obstetric crisis management.
And what's fascinating here, and what the elite professional really recognizes, is how a seemingly subtle inefficiency, maybe just a slight flattening on the labor curve, how that can escalate, sometimes exponentially, to a catastrophic mechanical crisis if those underlying mechanical signs are missed.
Right.
We absolutely need to distinguish clearly between a labor that's just slow, what we call a protraction disorder, and one that is physically arrested, stopped, blocked.
Okay, let's unpack this then, and we'll start right at the beginning, defining the boundaries. Where does labor cross that fundamental line into the classification we call prolonged?
Well, at its most basic, sort of historical definition, prolonged labor happens when the combined time of the first stage and the second stage goes over an arbitrary limit. Often, that limit was set at 18 hours.
18 hours, but just using total time. That can be really misleading, can't it?
Deeply misleading, yeah, because it doesn't tell you anything about the efficiency of the contractions or the actual progress being made within that time.
That distinction feels like the key insight here. Prolonged labor, the duration itself, isn't necessarily the same thing as ineffective contraction.
Exactly. That's a critical point. While inefficient uterine contraction, a problem with the power, is often a cause. Labor might also be prolonged because of factors in the pelvis, the passage, or issues with the baby, the passenger.
So it's a diagnosis based on time, but the real reason, the etiology, you have to look elsewhere.
Precisely. And to move beyond just watching the clock, the World Health Organization, this is back in 1994, they standardized the definition. They focused purely on the rate of change.
Okay, so how did they define it?
They stated, labor is considered prolonged if, over a minimum observation period of 4 hours, you see one of two things. Either the cervical dilatation rate is less than 1 centimeter per hour.
Less than 1 centimeter an hour.
Or the descent of the presenting part, the baby moving down, is less than 1 centimeter per hour.
Got it. So that's the definition that forces you, the clinician, to act based on function, on progress, not just how long it's been.
Exactly right. It shifts the focus entirely. It's about anticipating where this delivery is heading, not just clocking the hours.
So let's contrast that. A labor lasting 18 hours might be okay if, say, the patient dilated steadily to 8 centimeters, and then just slowed down a bit at the end.
Potentially, yes, if progress was good initially. But contrast that with a patient who's been stuck at, say, 5 centimeters for 4 straight hours, dilating at maybe half a centimeter per hour.
Right.
That's immediately flagged as pathological under the WHO criteria. Action is needed.
Okay, let's dive deeper into the stages now. Specifically, the prolonged latent phase. And this is that preparatory phase, right? Often confusing for everyone involved, happening before active labor truly starts. We need the numbers here, normal versus abnormal timing.
Okay, the normal mean duration, on average, is about 8 hours for a first-time mother, a prima gravida, or preemie.
8 hours.
And for a woman who's delivered before, a multipara or it's shorter, around 4 hours on average.
Okay.
Now, we classify it as abnormal, as prolonged, if that latent phase exceeds 20 hours in a preemie.
20 hours. Wow.
Or 14 hours in a multi.
14. Okay, those are the thresholds. What typically causes this early phase to stall? The sources list quite a few things.
Yeah, whole constellation. An unripe cervix, that's a big one.
Yeah.
Malposition of the baby, like OP, or a malpresentation. And always lurking is the possibility of cephalopelvic disproportion, CPD basically, a mismatch between the baby's head and the mother's pelvis. And don't forget the things we might do, the iatrogenic causes.
Right,
Like premature rupture of the membranes, the induction process itself, or, and this is important, giving regional anesthesia like an epidural too early before the cervix hits that true active phase dilation around 4 centimeters. That can definitely slow things down initially.
Okay, so despite the patient finding it incredibly frustrating, and I imagine a 20-hour wait is incredibly frustrating,
Oh, absolutely.
the critical clinical takeaway seems to be that a prolonged latent phase on its own usually doesn't endanger the mother or the fetus.
Generally, that's true. It's worrisome, but not typically dangerous in itself.
So what's the standard management approach then?
The default is expectant management. Rest, and maybe some pain relief and analgesic. The idea is to let the patient rest, conserve energy, and often she'll transition into active labor naturally.
And if you do decide augmentation is needed, maybe for maternal exhaustion.
If augmentation is chosen, the sources really emphasize using medical methods first, things like oxytocin or prostaglandins.
Okay, medical methods preferred. And here's a detail that seems crucial, something that could catch out someone unprepared. Amniotomy, deliberately breaking the waters, is usually avoided in the prolonged latent phase. Why is that restriction so firm?
It comes down to infection risk. Once you break the membranes, you open a pathway for bacteria to offend from the vagina into the uterus. That's chorioamnionitis.
Right.
If you know the latent phase is prolonged, but not immediately dangerous, doing an amniotomy just starts the clock on that infection risk. Waiting until true active labor is established minimizes the time the baby is exposed if labor continues to drag on.
Makes sense. And the definitive management principle here, a prolonged latent phase is absolutely not an indication for an immediate C-section.
Correct. This really highlights where clinical experience matters, knowing when to wait, when to support, and reserving C-section for true active phase problems or fetal distress.
Okay, now we move into the active first stage. Delay the failure of the cervix to dilate appropriately once active labor should be underway. To really master this, we need to immediately use that framework. Power, passage, or passenger. Where's the fault?
Right, let's break it down. Starting with power, the engine of labor. A fault in power means abnormal uterine contractions. Most commonly, this presents as uterine inertia.
Inertia meaning weak?
Yeah, basically the contractions are there, but they lack the necessary intensity or duration, or they're not frequent enough to make the cervix change.
Yeah.
Less common is incoordinate uterine contraction, where the contractions are chaotic, uneven, just not working effectively together.
Okay, that's power. What about the passage? Faults here mean physical resistance, right?
Exactly. The most common issue is a contracted pelvis bony disproportion. But soft tissue obstructions are definitely on the list too. Things like cervical dystocia, often from scarring due to previous surgery, or a pelvic tumor like a fibroid lowdown, or even something simple but surprisingly effective at blocking things a really full bladder.
A full bladder, right. Simple but obstructive. And finally, the passenger. Fetal issues. This covers anything about the baby that's impeding progress.
Yep. Malposition is a big one, like occiput posterior OP, where the back of the baby's head is towards the mother's spine. That often means a longer, tougher rotation is needed.
Okay.
Then there are frank malpresentations, like a face or brow presentation, and congenital anomalies, where hydrocephalus, that large head due to fluid, is a major mechanical blocker. We'll discuss more later.
Now, here's where it gets tricky in practice, isn't it? The source materials really emphasize that it's often a combination of factors.
Oh, absolutely. Rarely is it just one clean thing.
For instance, they mention injudicious, meaning early use of sedatives or analgesics before active labor really starts.
Right.
That can combine with maybe a slightly deflexed head.
A head that isn't tucked nicely.
Right. Or even minor degrees of pelvic contraction. And together, these things have, as the text says, sinister effects in causing the cervix not to dilate. The failure isn't just one P, it's the convergence.
That's a crucial point for the learner. It means if you try augmenting labor with oxytocin, boosting the power, and it doesn't fix the problem, you have to swiftly conclude the primary fault must lie with the passage or the passenger. And then you need to pivot quickly, probably towards considering a cesarean section. You can't just keep pushing the power if there's a mechanical block.
Okay, let's talk about the critical diagnostic tool here, the partograph.
Yeah.
How do we actually use this graph to diagnose active first-stage delay, getting beyond just looking at the clock?
The partograph provides that standardized, visual, objective measure of cervical dilation plotted against time. The modified WHO partograph is the standard.
And it defines the phases clearly.
Yes. The latent phase ends and the active phase begins when the cervix hits 4 centimeters dilation. From that point on, ideally, the cervix should dilate at least 1 centimeter per hour. The partograph maps this out visually.
And it uses those two specific lines that trigger a response, right? The alert line and the action line.
Exactly. Those lines are your decision points.
Okay, walk us through the clinical significance. The alert line, that's the first warning.
That's your heads up, yeah. The alert line starts at that 4 centimeter mark and projects forward, assuming that minimum 1 centimeter per hour rate. It basically shows the slowest acceptable rate of progress to get to 10 centimeters in 6 hours from the start of the active phase.
Okay.
When the patient's actual cervical dilation curve crosses that alert line, drifts to the right of it, putting them into what's called zone 2 on the graph, that's the flag,
Yeah.
labor is now officially abnormal.
And what do you do when it crosses the alert line?
Immediate, detailed reevaluation. Check the 3 Ps again. Do a vaginal exam. What's the presentation, position, station? Reassess the pelvis clinically. How strong are the contractions, really? This is the point for increased surveillance and assessment. Think. What is this slowing down?
And then there's the action line. That sounds more definitive.
It is. That's the point of, well, required action. The action line is drawn parallel to the alert line, but 4 hours to the right of it.
4 hours later.
4 hours later. If the patient's dilation curve crosses that line, falling into zone 3, intervention is now mandatory. No more waiting.
And intervention means?
It means either active augmentation of labor, usually amniotomy if not already done, and starting or increasing oxytocin if, and only if, you're confident that inadequate power is the sole issue.
But more commonly?
More commonly, especially if there are signs of mechanical obstruction, passage or passenger issues, crossing the action line means moving towards an immediate cesarean delivery. That 4-hour gap between alert and action gives the clinical team a window to reassess, maybe try augmentation carefully before making that final decision.
That clarity is really helpful, and it allows us to categorize the specific disorders of the active phase. Now, you mentioned protraction versus arrest earlier. The management depends crucially on which one it is.
Absolutely. Protraction disorders mean labor is slower than normal, but it is still progressing, albeit slowly.
How slow is protracted?
We define it as cervical dilatation being less than 1.2 centimeters per hour in a prima para, or less than 1.5 centimeters per hour in a multipara.
Okay, slightly different rates. And the causes?
Often it's just suboptimal uterine contractions that might respond well to oxytocin. Or it could be a malposition like OP that's making things harder. Or sometimes the effect of regional anesthesia slowing things down.
Then we escalate to arrest disorders. This means a complete stop in progress, signaling a much more serious underlying problem, usually.
Right. Arrestive dilatation means absolutely no change in the cervix for 2 hours or more during the active phase. If the contractions are clearly weak, this might just be very inefficient uterine power. But the much more sinister diagnosis is arrestive descent. This means no downward movement of the baby's head, no change in station for more than 2 hours.
And why is that more sinister?
Because while really poor contractions could cause it, arrestive descent, especially with decent contractions, strongly suggests a fixed mechanical barrier. It's very commonly due to cephalopelvic disproportion, CPD.
Ah, okay. So the distinction is vital. Is the halt due to power failure or a passage passenger block?
Fundamental. Because it determines if you can safely try to augment the power, or if you absolutely must intervene surgically to bypass the block in the passage or deal with the passenger issue.
We also need to touch on secondary arrest. What's that?
Secondary arrest is when the active phase starts off perfectly normally. The curve looks great on the partograph initially, but then it just stops or slows dramatically for 2 hours or more before the patient reaches full dilatation.
And the cause there?
Again, once you rule out power failure, this often points back to a malposition the uterus just can't overcome, or underlying CPD that only became apparent once labor was well established and the uterus started to tire against the resistance.
And lastly, the combined disorder. Sounds ominous.
It is. That's when you see an arrest of dilatation or descent happening in a woman whose labor was already protracted, already slow.
So slow progress followed by a complete stop.
Exactly. These cases have a much lower chance of successful vaginal delivery because it suggests there were already underlying issues, and now they've hit an insurmountable barrier. The prognosis is more guarded, and you usually need to move to C-section more quickly.
All right, let's move into the second stage of labor, the pushing phase. Normally, it's pretty quick, right? The mean duration is only about 50 minutes for a first-timer, a nullipara.
And just 20 minutes for a multipara. Relatively short, yes.
So when does this critical phase become officially prolonged according to modern standards, like ACOG?
The American College of Obstetricians and Gynecologists, ACOG, sets the criteria. They define a prolonged second stage if it exceeds 2 hours in a nullipara.
2 hours.
Or 1 hour in a multipara. But that's the baseline without regional anesthesia.
Ah, okay. What about the regional anesthesia exception? That's important clinical nuance.
It really is. When regional anesthesia, like a standard epidural, is being used, those time limits are often relaxed. ACOG generally allows an extra hour, sometimes more, in both groups.
So potentially 3 hours for a nullipara with an epidural, 2 for a multi. Why the extra time?
Because the epidural significantly dampens the reflex urge to push. It also reduces the effectiveness of the mother's voluntary bearing down efforts. So the clinician needs to exercise more patience, provided the fetal heart rate tracing is reassuring, and you can see some slow, steady progress happening. You give it more time.
Got it. And the causes of this sluggish or non-descent in the second stage, do they mirror the first stage issues?
Largely, yes, fitting into our power passage passenger framework again. Fault in power could be uterine inertia carrying over, or the mother simply being unable to bear down effectively. Regional analgesia is a big factor here. Or, more physically, sometimes a constriction ring can form in the uterus, trapping the baby.
Okay, passage.
Passage issues still include CPD, that pelvic mismatch, but also you can get undue resistance from the pelvic floor muscles. The soft tissues just aren't yielding, or significant scarring, maybe from previous surgery or tears.
And passing.
Still the fetal factors. Malposition like persistent OP is common here. A clinically big baby making it through the outlet. Or a congenital malformation becoming apparent right at the end.
How do we specifically define the disorders of descent in this second stage? Is it similar to the first stage definitions?
Yes, similar concepts. Protraction of descent is defined as progress slower than 1 centimeter per hour in a nullipara, or less than 2 centimeter per hour in a multipara. Still moving, but slowly.
And arrest.
Arrest of descent is diagnosed when there's absolutely no downward movement, no change in station observed over at least 2 hours, sometimes less, depending on the clinical picture.
And an arrest in the second stage. That's a major red flag, right?
Huge red flag. It points very strongly towards likely CPD, persistent malposition like OP, maybe inadequate contractions finally giving out, or perhaps asynclitism, where the baby's head is tilted improperly and just can't negotiate the pelvis.
It makes sense why we track these hours and centimeters so meticulously. Because the consequences, the dangers of prolonged labor, especially in the second stage, are severe for both mother and baby. Let's unpack those dangers.
For the fetus, the risks really multiply significantly as labor drags on, especially in the second stage. Hypoxia is the primary concern.
Lack of oxygen. Why does that happen?
It's often due to diminished blood flow through the placenta. Think about it. Strong, frequent contractions pushing against a blockage, or maybe the membranes ruptured a long time ago, or cord compression issues.
Yeah.
It all compromises oxygen delivery.
And that leads to?
Fetal acidosis. You can actually measure this sometimes via fetal scalp blood pH sampling, confirming distress.
What else?
There's the risk of intrauterine infection, especially if membranes are ruptured. That can lead to neonatal pneumonia after birth. But perhaps the most direct traumatic risk is mechanical.
From the pressure.
Yes, intracranial stress or even hemorrhage. This can happen from that prolonged stay jammed in the perineum, often associated with excessive molding and compression of the skull, what the texts call supermolding of the head.
It's awful.
It is. And all of this together contributes to a sharp increase in the need for operative delivery, forceps, or vacuum, and sadly, increased perinatal morbidity and mortality.
And for the mother, the list of risks seems just as concerning.
Absolutely. Immediate risks include maternal exhaustion, profound distress, and often chorioamnionitis, that uterine infection. Longer term, there's a significantly higher risk of postpartum hemorrhage, PPH.
Why the PPH risk?
Often due to uterine atony, the uterine muscle is just exhausted after prolonged, inefficient work, and it fails to contract down properly after delivery. Or it could be due to trauma.
Let's talk about that trauma. The source mentions trauma to the genital tract as a key long-term legacy.
Yes, and it can be obvious. Revealed trauma like severe tears of the cervix or vagina, or in the absolute worst-case scenario, rupture of the uterus itself.
But it can also be hidden.
Exactly. Concealed trauma. This is the excessive stretching and damage to the pelvic floor muscles and the supporting ligaments. This might not be obvious immediately, but it can lead to chronic problems down the road, like future uterine prolapse or stress urinary incontinence.
So lifelong consequences, potentially.
Potentially, yes. Furthermore, prolonged labor clearly increases the need for operative delivery, whether that's a difficult instrumental vaginal delivery or a complicated cesarean section. Both carry their own risks. And after delivery, there are higher rates of puerperal sepsis, postpartum infection, and subinvolution, where the uterus doesn't shrink back to its normal size properly.
It really paints a picture of a cascade of potential problems.
It does. The combined effects of potential shock, hemorrhage, infection, and exhaustion are why prolonged labor, especially when it tips into obstruction, remains a major cause of maternal morbidity and even mortality globally.
Okay, so if prolonged labor is that taxing, difficult journey, obstructed labor is something else entirely. It's a complete structural failure. We need to make that conceptual leap now, from slow progress to the definitive diagnosis of a mechanical crisis.
The definition here is absolutely paramount. You have to get this right. Obstructed labor is defined as a labor where the progressive descent of the presenting part is arrested due to mechanical obstruction,
Mechanical obstruction.
in spite of good uterine contractions. That's the crucial differentiator from simple uterine inertia or hypotonic dysfunction.
So the engine, the power is working fine, maybe even working too hard.
Exactly. The uterine muscle is often contracting fiercely, powerfully, sometimes painfully so, but the path is physically blocked. Further progress is virtually impossible without assistance to remove or bypass that obstruction.
It's important context, I think, that the source material notes the incidence. While thankfully rarer now in high-resource settings with good monitoring, it remains a major crisis in many developing countries. They report an incidence of about 1 to 2% in referral hospitals. It underscores that this is still a critical global health issue.
Absolutely. It's far from just a historical problem.
So let's break down the mechanical causes again using our framework. Fault in the passage, the pathway. What are the common culprits for true obstruction?
Under passage, the most common bony causes are, again, cephalopelvic disproportion, CPD, and a generally contracted pelvis. That's the classic mechanical block.
But it's not just bone, right? Soft tissue obstructions.
Just as critical, things like severe cervical dystocia, maybe from previous cone biopsy scarring, making the cervix rigid and unable to dilate, or large fibroids located low down in the uterus or cervix, an impacted ovarian tumor blocking the lower pelvis, or even, rarely, the non-pregnant horn of a bicornuate uterus getting trapped below the baby's presenting part.
Okay, and fault in the passenger, the baby itself, acting as the obstruction?
This includes severe malpresentations, like a transverse lie, baby sideways, or a brow presentation, forehead first. Simple mechanical blockage just from a very big baby, macrosomia. Or the commonest congenital malformation causing true obstruction, hydrocephalus, that very large head.
What else is listed?
Fetal ascites, fluid in the baby's abdomen. Conjoined twins, double monsters is the old term. Compound presentation, like a hand alongside the head. Or locked twins, all mechanical blocks.
Now, the morbid anatomical changes that happen in the mother during true neglected obstructed labor, these sound severe and progressive. It creates a vicious cycle of deterioration.
It really does. The uterus, faced with an insurmountable obstruction, responds by hypertrophying. The muscle gets thicker and contracting more and more strongly, trying desperately to overcome the block. This eventually leads to a very specific, ominous physical sign.
You mean the pathological retraction ring, Bandel's ring?
Exactly. Bandel's ring. We need to spend a moment on this because recognizing it is critical.
Okay, what is it visually or palpably, and why is seeing it such a sign of impending disaster?
Bandel's ring is a palpable and sometimes even visible indentation or ridge that forms across the uterus. It marks the boundary between the actively contracting, thickening upper uterine segment and the dangerously thinned out, stretched lower uterine segment.
So the lower part is stretching over the obstruction.
Precisely.
Yeah.
It's being stretched incredibly thin as the baby's head, or other presenting part, is relentlessly forced down against the pelvic brim or other blockage. Seeing or feeling this ring rise up the abdomen, getting higher and higher above the pubic bone, the symphysis pubis, That is the ultimate clinical warning sign.
Meaning?
Meaning uterine rupture is imminent. The lower segment is reaching its absolute breaking point. It's a sign of extreme, prolonged, neglected obstruction, a true surgical emergency.
And the trauma isn't just to the uterus. The bladder damage sounds equally devastating.
It is. Because of that intense, prolonged compression of the bladder neck and the urethra trapped between the baby's head and the mother's pubic bone, the bladder gets pushed up, distended, almost becomes an abdominal organ. And this continuous pressure causes a truly sinister complication.
You're talking about pressure necrosis.
Pressure necrosis, yes. The tissue of the bladder wall, starved of blood flow where it's being compressed, dies. Later on, maybe days after the delivery, this devitalized tissue slows off.
Creating a hole.
A fistula, usually between the bladder and the vagina, a vesicovaginal fistula, or sometimes between the rectum and vagina, a rectovaginal fistula.
And the result is?
Chronic, devastating incontinence of urine or feces. It's one of the most severe long-term morbidities of neglected obstructed labor. And during the obstructed labor itself, finding blood-stained urine is a common, immediate warning sign that this severe pressure and trauma is occurring.
Looking at the immediate systemic maternal effects, the sources list exhaustion, dehydration.
Profound exhaustion and dehydration from the constant agonizing pain, the massive muscular effort, often without adequate fluid intake over many hours or even days.
And metabolic acidosis follows quickly.
Rapidly. From the buildup of lactic acid from muscle exertion under anaerobic conditions and ketones from starvation and dehydration. And genital sepsis is almost guaranteed, isn't it? Almost invariable, especially if the membranes have been ruptured for a long time or if there have been multiple, potentially non-sterile vaginal examinations trying to figure out what's going on.
It's a cascade then. Exhaustion, dehydration, acidosis, sepsis, leading potentially to uterine rupture, massive hemorrhage, shock, and death.
That's the tragic cascade, yes. Those are the factors often cited in maternal deaths from obstructed labor.
And even if the mother survives the immediate crisis, those profound remote legacies you mentioned, the fistulas, vaginal scarring or narrowing, atresia, maybe secondary amenorrhea if a hysterectomy was needed, or from pituitary damage like Sheehan's syndrome.
Heartbreaking, life-altering consequences.
And for the fetus caught in this, the outlook sounds incredibly grim.
It is. Fetal asphyxia is extremely common. Either because the tonic, relentless uterine contractions are squeezing the placenta so hard that blood flow stops, or from cord prolapse, which can happen when the fit isn't good.
Leading to acidosis again.
Yes, severe fetal acidosis. Plus, intracranial hemorrhage is a high risk, either from that extreme head molding or from a potentially traumatic delivery attempt. And infection, of course. The perinatal loss rate in true neglected obstructed labor is tragically high.
So the moment true obstruction is diagnosed, the game changes completely.
Completely. The urgency shifts instantly from monitoring progress to planning immediate, safe relief of the obstruction, usually surgical.
Okay, let's pivot now to focus specifically on those passenger issues, problems with the baby itself that create dystocia, difficult labor. Let's start with macrosomia, defined simply as an abnormally large baby, right? Usually weighing more than 4 kilograms, or about 8 pounds, 13 ounces.
And there's the general definition, yes, over 4 kilos.
What are the common drivers for having such a large baby?
Well, some are non-modifiable basic genetics, race, parents being large themselves, the baby being male tends to be slightly bigger. Multiparity, having had previous babies, also correlates. Post-maturity, going significantly past the due date, allows for more growth.
But what's the single most actionable cause, the one we can potentially influence?
That would be poorly controlled maternal diabetes, either pre-existing or gestational diabetes.
How does diabetes lead to a big baby?
The high maternal blood sugar crosses the placenta, stimulating the fetal pancreas to produce excess insulin. Fetal hyperinsulinemia then acts like a growth hormone, causing the deposition of fat, particularly around the baby's shoulders and trunk. This pattern of growth significantly increases the risk of a specific mechanical complication.
Shoulder dystocia.
Exactly. Macrosomia is a major risk factor for shoulder dystocia, and also for just general surprise dystocia where labor stalls unexpectedly.
So how do we manage this risk proactively if we suspect or know the baby is macrosomic?
Management really focuses on prevention of the emergency. One option is prophylactic induction of labor, perhaps a bit early, if the cervix is favorable and the estimated size isn't excessive. Or, more commonly now, especially for significantly large babies or in diabetic women where the risk of shoulder dystocia is even higher, the recommendation is often for an elective cesarean delivery. Just bypass the risk of the shoulders getting stuck altogether.
Okay, let's do the deep dives now into shoulder dystocia itself, SD. This is arguably one of the most frightening obstetric emergencies because it happens after the baby's head is already born.
It is terrifying, yes. High adrenaline situation.
And the definition is key. It requires additional obstetric maneuvers to deliver the shoulders after the head is born, and gentle, routine downward traction has failed to release the anterior shoulder.
That's the core of it. Gentle traction isn't working. You need to do something else.
What's the mechanism? Why do the shoulders get stuck?
Typically, it's the anterior fetal shoulder getting impacted, wedged behind the mother's pubic bone, the symphysis pubis. Less commonly, the posterior shoulder might get caught on the sacral promontory in the back of the pelvis.
And the incidence, you hear about it a lot, but how common is it really?
The incidence is relatively low, maybe 0.2% to 1% of vaginal deliveries, but when it happens, the potential for significant morbidity, for harm to the baby, is very high, so it's a major concern.
The diagnosis has to be lightning fast, based purely on clinical signs right after the head delivers. What are we looking for? What screams shoulder dystocia?
The absolute classic hallmark sign is the definite recoil of the baby's head back against the perineum immediately after it emerges. It pops out, then pulls back tightly. That's the famous turtleneck sign.
Turtleneck sign, got it. What else?
You might also see a failure of the normal spontaneous rotation of the fetal head after it's born, restitution. The baby's face might look very flushed or purplish, plethoric, due to chest compression. And fundamentally, a definitive failure of the shoulder to descend into the pelvis with the next contraction and maternal pushing effort.
The clock starts ticking the instant the head is born, doesn't it? Fetal complications can happen fast.
Very fast. The main risks are asphyxia, lack of oxygen, either from compression of the umbilical cord trapped in the pelvis or simply the baby being unable to expand its chest to breathe while the shoulders are stuck.
And the other major risk is nerve damage.
Yes, brachial plexus injury or plexopathy, stretching or tearing of that bundle of nerves running from the neck down the arm. This can cause Erb's palsy affecting the upper arm or Klumpke's palsy affecting the hand. And sometimes, sadly, fractures of the baby's humerus, upper arm bone, or clavicle, collarbone, can occur during the difficult delivery.
Okay, management. This needs to be a practice drill, almost automatic. There are mnemonics like help her, right? What are the absolute first steps?
The first two steps are critical and should happen almost simultaneously. 1. Help. Call for extra help immediately. NICU team, anesthesia, another obstetrician, senior midwife. You need more hands.
Okay, call for help. And 2.
2. Evaluate for episiotomy. A generous medial-lateral episiotomy doesn't release the bony obstruction, but it creates more room posteriorly for subsequent maneuvers. And critically, tied into calling for help, is what not to do. Never apply fundal pressure.
Right, this is emphasized everywhere. Why is pushing on the top of the uterus, fundal pressure, absolutely contraindicated here?
Because it does the worst possible thing. It pushes the impacted anterior shoulder even harder down into the pelvis, wedging it more firmly behind the pubic bone. It increases the force of impaction, likely prolongs the dystocia, and significantly increases the risk of fetal injury, especially that brachial plexus damage. It makes things worse.
Okay, so help called, episiotomy considered, NO fundal pressure. What's the first actual physical maneuver to try?
The first specific maneuver, often combined with suprapubic pressure, is the McRoberts maneuver. This is the single most effective first-line action.
What does McRoberts involve?
You need assistance to grab the mother's thighs, thoroughly abduct them, move them apart, and then sharply hyperflex them right up onto her abdomen, knees towards her armpits, basically.
And how does that help?
This simple position change does two things. It straightens the natural curve of the lower spine, the lumbosacral angle, and it rotates the entire maternal pelvis upwards slightly. The key effect is increasing the front-to-back dimension, the anterior-posterior diameter of the pelvic inlet. This often provides just enough space for the impacted shoulder to slip free.
And it's very effective.
Remarkably so.
How?
The sources say it's successful in resolving the dystocia in about 90% of cases, often combined with suprapubic pressure applied just above the pubic bone by an assistant to try and push the anterior shoulder down and under the bone.
90% is huge. But if McRoberts, with suprapubic pressure, fails, what's the next step in the algorithm?
Then you move to internal rotational maneuvers. The Wood's corkscrew maneuver is a common next step.
Wood's corkscrew. What's that?
This involves the obstetrician inserting fingers into the vagina, usually reaching the posterior aspect of the baby's posterior shoulder. You then try to rotate that posterior shoulder 180 degrees like a corkscrew, sweeping it across the baby's chest towards the front.
What's the goal of that rotation?
The goal is to dislodge the impacted anterior shoulder by rotating the baby's entire shoulder girdle, moving the obstruction out of that tight anterior-posterior diameter and hopefully into the wider oblique diameter of the pelvis.
Okay, McRoberts, then Wood's corkscrew. What other rescue techniques are there if those don't work?
Another common one is delivery of the posterior arm. You reach into the vagina, past the baby's body, grasp the posterior arm, flex the elbow across the chest, and sweep the arm out of the vagina. This reduces the shoulder-to-shoulder diameter significantly, often allowing the anterior shoulder to deliver.
But that sounds risky.
It is effective, but it carries a definite risk of fracturing the baby's humerus or clavicle during the maneuver. It's a trade-off in an emergency.
Any other positions?
Changing the mother's position to the all-fours position, gasket maneuver, on her hands and knees can be very effective. It uses gravity and changes pelvic diameters, but it's really only feasible if the mother is mobile and doesn't have a dense epidural.
Okay, those are the main maneuvers. What about extreme measures, reserved for when absolutely everything else has failed and the baby's life is in immediate danger?
These are truly last resorts. One is the deliberate fracture of the fetal clavicle. You intentionally snap the collarbone to reduce the shoulder width. It sounds brutal, but it usually heals very rapidly in newborns.
Wow. Anything else?
Very rarely, the Zavanelli maneuver might be attempted. This involves pushing the baby's head back up into the uterus.
Pushing it back in.
Yes. Reversing the delivery, followed by an immediate emergency cesarean section. It's a desperate measure with very high risks of maternal trauma and fetal hypoxia. And finally, for a baby that has tragically already died, or perhaps an anencephalic baby where survival isn't expected, cleidotomy, surgically cutting the clavicle, might be performed to facilitate delivery.
A truly complex and terrifying emergency drill. Okay, let's move on to other fetal anomalies causing dystocia. Hydrocephalus, that excessive fluid in the baby's head.
Right, hydrocephalus. This is an excessive accumulation of cerebrospinal fluid, CSF, within the ventricles of the brain. We're talking maybe half a liter to 1.5 liters of extra fluid. It occurs in roughly 1 in 2,000 deliveries and is often linked to neural tube defects like spina bifida.
How is it typically diagnosed?
Clinically, the head feels obviously large, maybe over 50 centimeters in circumference, and often high up, not engaged in the pelvis. On internal vaginal exam, you might feel widely gaping sutures and fontanelles, the soft spots, and sometimes a characteristic crackling sensation like parchment paper when you press on the thin skull bones.
And ultrasound confirms it.
Ultrasound is definitive. It shows those markedly dilated brain ventricles and a very thin rim of remaining cerebral cortex.
The prognosis for the baby is generally very poor, isn't it?
Extremely poor, unfortunately. It often leads to stillbirth or neonatal death shortly after birth. Survivors typically have severe developmental delays, but the immediate threat during labor is actually to the mother.
How so?
Because that very large, hard, non-compressible head poses a severe risk of obstructed labor. It simply cannot fit through the pelvis. This can lead to uterine rupture, sometimes even before the cervix is fully dilated, just due to the extreme stretching of the lower uterine segment over that massive head.
So given the poor fetal prognosis and high maternal risk, what's the principle of management?
The principle is urgent decompression of the head to reduce its size. This is called cephalocentesis.
How is that done?
It involves puncturing the fetal skull, either transvaginally during labor, or sometimes transabdominally, or during a C-section using a sharp instrument like pointed scissors, or, more commonly, a wide-bore needle like a 17-gauge spinal needle. You drain the excess CSF.
Then that allows delivery.
Yes. Reducing the head size immediately relieves the obstruction and allows for safe vaginal delivery or easier extraction during C-section, prioritizing the mother's safety above all else in this situation.
Okay, another severe neural tube defect mentioned is anencephaly.
Anencephaly, yes.
Right.
This is where the vault of the skull and most of the brain tissue fail to develop. It occurs about 1 in 1,000 births. The face often looks surprisingly normal, but there's no upper skull or brain.
What are the key obstetrical complications associated with anencephaly?
Firstly, it's very frequently associated with hydramnios, excessive amniotic fluid, in up to 70% of cases, which can cause maternal discomfort or premature labor. More significantly, these fetuses often have an absent or very poorly developed pituitary gland. This leads to markedly reduced fetal adrenal gland function, resulting in very low levels of fetal cortisol and, consequently, low estriol production.
And what's the clinical implication of those low hormone levels?
The key implication is that the mother's uterus often becomes refractory or unresponsive to standard labor induction agents like oxytocin, pitocin.
So induction is difficult.
It can be very difficult with oxytocin alone. Therefore, the preferred method for terminating the pregnancy or inducing labor in late pregnancy, once anencephaly is diagnosed, is often using prostaglandin vaginal gel, like PGE2, dinoprostone, which works directly on the cervix and uterus, bypassing the need for the fetal hormonal contribution.
And even with anencephaly, shoulder dystocia can still be an issue.
Yes, surprisingly. Sometimes the shoulders and trunk are disproportionately large even without a brain. If shoulder dystocia occurs with an encephalic fetus, management might involve destructive procedures like clitotomy, given the lack of potential for survival.
And it's worth repeating the preventative message here.
Absolutely. High-dose folic acid supplementation, 4 milligrams daily, ideally starting at least 1 month before conception and continuing through the first trimester, significantly reduces the incidence of all neural tube defects, including anencephaly and spina bifida, by up to 85%. A major public health intervention.
Okay, finally, just quickly touching on other rare fetal causes of dystocia mentioned in the sources. Enlargement of the fetal abdomen.
Yes, this can cause dystocia after the head is born. The abdomen might be hugely distended due to things like fetal ascites, fluid, a massively distended bladder, for example, from posterior urethral valves, or sometimes a large kidney tumor like a Wilms tumor.
How's that diagnosed and managed?
Ultrasound might show the characteristic Buddha position with the large abdomen. In labor, if the head delivers but the body is stuck, you might feel the hugely distended abdomen. The management is usually straightforward. Puncture the fetal abdomen with a wide-bore needle to decompress it, allowing the trunk to deliver spontaneously.
And conjoined twins. Extremely rare, but a definite mechanical block.
Extremely rare, yes. Diagnosis needs detailed ultrasonography, maybe 3D ultrasound or MRI, to confirm they are joined, see the extent of connection, and crucially determine which organs are shared.
Management options.
Extensive counseling for the parents is key. Termination might be an option. If the pregnancy continues, cesarean section generally offers the best chance of delivering potentially viable twins who might be candidates for surgical separation later. If the twins have already died in utero, a destructive operation to separate them might be necessary to relieve the obstruction and deliver the mother safely.
All right, to really achieve that professional mastery we talked about, we need to synthesize all this into a definitive management strategy. Let's start with prevention and the crucial preliminary steps, especially when dealing with neglected cases arriving late.
Prevention really starts antenatally, doesn't it? Early detection of risk factors. Is the baby likely to be big? Is the mother's pelvis small? Is there a malpresentation? And then, during labor itself, constant, vigilant use of the partograph is key for early detection of deviation from normal progress. Standard practices that help include judicious augmentation when needed, often a combination of low rupture of membranes, amniotomy, followed by careful oxytocin infusion. Also, simple things like encouraging changes in posture, avoiding the supine position, which can hinder progress, ensuring good hydration, and providing adequate pain relief.
Yeah.
Emotional support is huge, too.
Okay, but what about those neglected cases? The patient arriving late at a referral hospital, already in prolonged or obstructed labor, may be dehydrated, exhausted.
Right, those crisis situations often seen in lower resource settings. The absolute immediate priority before anything else is resuscitation. You have to correct the mother's dehydration and life-threatening ketoacidosis aggressively. Rapid intravenous infusion of fluids, typically Ringer's lactate or normal saline. The sources explicitly state that at least 3 liters are often needed immediately just to correct the clinical signs of dehydration and start reversing the metabolic acidosis.
3 liters straight away. Wow.
Yeah.
What other safety checks are mandatory in that situation?
You need baseline labs and preparations. A vaginal swab for culture and sensitivity testing, because infection is highly likely, blood grouping and cross-matching, because hemorrhage is a major risk, and prophylactic broad-spectrum antibiotics are essential, something covering gram-positives, negatives, and anaerobes, like a combination of ceftriaxone and metronidazole.
Okay, patient stabilized. Let's talk definitive treatment, starting with first stage delay. We've used the partograph. The curve is in zone 2 or 3. We've done our reevaluation. Vaginal exam confirms presentation, position, station, maybe clinical pelvimetry. Now what?
The management really diverges based on that reevaluation. If you are confident that the only issue is suboptimal uterine activity, the power is weak, then the intervention is usually amniotomy. if membranes are still intact, and starting or increasing in oxytocin infusion. Effective pain relief, like an epidural, can also sometimes help by allowing the mother to relax.
So you try to fix the power
We
problem.
try to fix the power problem, yes.
However,
Big however, if secondary arrest occurs, meaning labor stops after progressing well, or if there's any clinical suspicion of CPD or a malposition that's unlikely to resolve, especially in a multiparous woman whose uterus might be less resilient or scarred, you have to be extremely cautious about starting or pushing oxytocin.
why the caution, especially in a multi-para?
Because you risk hyperstimulating a uterus that might be thinning over an obstruction, potentially leading to uterine rupture. The threshold for deciding augmentation is unsafe should be lower in a multi-para with arrest.
So what's the key intervention then, if augmentation is deemed unsafe or fails?
The key intervention is recognizing the limit. Cesarean section is performed promptly when vaginal delivery is judged to be unsafe due to that mechanical blockage, the passage or passenger problem, or if fetal distress develops.
Okay, now for second stage delay. Patients fully dilated, pushing, but progress stalls. What's the approach?
If the fetal heart rate tracing is reassuring and it looks like vaginal delivery is really imminent, maybe the head is right there on the perineum. A short period of continued expectant management, maybe changing maternal position, is reasonable. Give it a little more time.
But if delivery isn't imminent, or the FHR is worrying,
Then you must proceed to appropriate assisted delivery. That usually means operative vaginal delivery with forceps or vacuum extraction if the conditions are suitable, head low enough, position known, etc. Or if operative vaginal delivery is contraindicated or likely to be too difficult, then you move to cesarean section.
and the mastery here is judging that difficulty.
Absolutely. The mastery lies in recognizing when an instrumental delivery is becoming too difficult, when excessive force might be needed. Difficult, traumatic instrumental deliveries should always be avoided in favor of a timely, safe cesarean section.
Now, the absolute crisis. Obstructed labor, mechanical block, good contractions, Bandel's ring might be forming. But the core principles here sound non-negotiable.
Totally non-negotiable. 1. Relieve the obstruction at the earliest possible moment by the safest procedure available. 2. Continue aggressively combating the systemic collapse, dehydration, ketoacidosis. 3. Control sepsis with antibiotics.
And the golden rule that overrides everything.
The golden rule is uterine rupture must be immediately excluded or considered imminent. Every decision must prioritize maternal safety above all else. And flowing from that, there is absolutely no place for wait and watch, and neither is there any scope whatsoever for using oxytocin.
Reinforce that. Why absolutely no oxytocin in obstructed labor?
Because the uterus is already contracting powerfully against an immovable object. Adding oxytocin would only intensify those contractions, further stretch the thinned-out lower segment, and dramatically increase the risk of catastrophic uterine rupture. It's like pouring gasoline on a fire.
Got it. So oxytocin is out. The choice then boils down to how to relieve the obstruction, attempt vaginal delivery, or go straight to C-section.
The decision depends heavily on the status of the baby and the clinical circumstances. If the baby has tragically already died, which sadly is common in neglected obstructed cases arriving late, then often the safest procedure for the mother is a destructive operation.
Destructive operation meaning?
Procedures like craniotomy, reducing head size, or decapitation or evisceration, depending on the presentation. These carefully performed procedures reduce the size of the fetus, relieving the obstruction quickly and allowing vaginal delivery, saving the mother from the risks of a major abdominal surgery, C-section, on top of her already compromised state from sepsis and exhaustion.
Okay. What if the baby is still alive? Can forceps be used?
Only, and very cautiously, if the baby is alive and the head is very low down in the pelvis, essentially already past the obstruction, making extraction straightforward without undue force or risk. Internal version maneuvers have absolutely no place here.
So, for most cases of obstruction with a live baby,
Cesarean section generally gives the best result for both mother and baby if the obstruction is detected relatively early and the baby is still in good condition.
but there's a trade-off if the case is late or neglected.
Yes. The sources warn that in late, severely neglected cases, performing a cesarean section in a desperate attempt to save a moribund baby, a baby near death, often leads to a very difficult, stormy maternal post-operative period.
Why is that?
Because the mother's tissues are already severely traumatized, ischemic, lacking blood flow, and likely infected. Surgery in that context carries extremely high risks of hemorrhage, widespread infection, poor healing, and overall maternal morbidity. Sometimes, tragically, a destructive operation might still be the safer option for the mother, even if the baby has a faint heartbeat but is clearly compromised. It's a terrible decision to have to make.
And finally, the sources mention symphysiotomy. What is that, and where does it fit in?
Symphysiotomy is a procedure where the cartilage of the symphysis pubis, the joint at the front of the pelvis, is surgically divided. This allows the pelvic diameter to widen slightly, potentially relieving outlet obstruction.
Where is this
It's primarily considered in some low-resource settings in developing countries as a potential alternative to a very risky cesarean section, perhaps due to lack of resources, blood bank, or surgical expertise. When there's established obstruction due to outlet contraction and the baby is still alive with a good heart rate. It allows vaginal delivery but carries risks of pelvic instability or damage to the urethra. It is largely abandoned in high-resource settings.
It really highlights the different calculations based on available resources.
Absolutely. This entire framework, though, from tracking that 1 centimeter per hour rate on the partograph, to knowing when to do a McRoberts, to understanding why oxytocin is poison in obstruction, it's all designed around managing risk and making timely, evidence-based decisions under often extreme pressure. #outro.
Wow. Okay, we have covered a huge amount of ground. We've gone from defining those subtle delays measured in centimeters per hour right through to the stark reality of mechanical barriers like Bandel's ring that signal impending rupture and demand major surgical intervention. We've clarified the reasoning why a clinician might prefer rest and analgesia over amniotomy in the prolonged latent phase, for instance.
Right, that infection risk calculation.
And why applying fundal pressure during shoulder dystocia isn't just unhelpful, it's actively dangerous, it's explicitly contraindicated.
Absolutely critical point. And I think the real mastery here, as we've discussed, lies in that nuanced diagnosis. Being able to reliably distinguish protraction slow progress that might respond to boosting the power.
Yeah.
Or arrest a dead stop that usually signals a passage or passenger failure requiring a different approach. It's about recognizing the significance of the partograph's alert versus action lines, understanding what they compel you to do, and internalizing the fact that every hour of unresolved delay, especially once obstruction sets in, exponentially increases the risk of those devastating long-term consequences like fistulas. The management isn't driven by panic, but by that precise methodical assessment of power, passage, and passenger, and the status of both mother and fetus.
So what does this all mean for you, the professional learner listening? I think it means really cementing that knowledge, knowing, for example, that while weak contractions, inadequate power, might be the most common cause of primary dysfunctional labor in a first-time mother.
In a nullipara, yes.
The diagnosis often pivots sharply towards cephalopelvic disproportion, a passage problem, when you're dealing with a multiparous patient who experiences an arrest in labor.
That's a key diagnostic heuristic. That difference immediately directs your entire clinical evaluation and your management plan. Is this likely fixable with oxytocin, or do I need to prepare for a C-section because of a likely mechanical issue?
This deep dive, hopefully, provides a really clear roadmap for recognizing these issues early, prioritizing interventions correctly, and managing these obstetrical emergencies with the kind of precision required of elite practitioners.
That's the goal.
Okay, let's end with a final provocative thought for you, the listener. Considering the dramatic and often lifelong risks associated with true obstructed labor, especially things like the formation of that pathological retraction ring, the potential for uterine rupture, and the devastating legacy of genitourinary fistulas, how might continued advancements in routine antenatal imaging, thinking about things like highly accurate fetal weight estimation through ultrasound, maybe even advanced pelvimetry using MRI or CT, how might these technologies continue to shift the balance away from reactive intervention during a difficult labor and more towards preventative, planned, elective delivery for those identified as being at very high risk before labor even begins?
That's a great question. The potential for better prediction is certainly there.
Something to think about. We really hope this deep dive was enlightening.